So let me introduce Amy Sitipati, who is the PI of the site on the Owen Clinic and is a healthcare provider with us, also a clinical informatics accredited professional. So Amy will talk about her experience at the intersection of research and quality improvement.
Hi. Thank you so much for having me. I'm delighted to be here. And I didn't know it, but I've been working in data a long time. I think more than 10 years my work has been really sifting through data, and I'm coming to this intersection where quality care delivery and research are sometimes meeting an intersection. And I'd like to talk to you a little bit about some of the lessons that I've learned, and I'm hoping that that might help you frame the work that you do in a little bit different way. So I've been working during this time in the past decade with very diverse patient populations, and currently I'm in a public health HIV care practice that's based at the university. But a key message that I wanted to share with you was the importance of good data. Now, I know you know this, but you may not think that I knew this because I've been working in the healthcare delivery sector. That means about the clinical care, patients coming into the practice who need better healthcare delivery. How does good data help me get them better care? How can this help you get your research participants to be better engaged in care? How can this collectively help us secure better big data? So I'm working in an incentive-based healthcare market, and in this market, CMS is partnered to try to have some new ways to improve both quality and efficiency for healthcare delivery. So I was the PI for Disrupt 5, which is HIV transitions. And this is a medical home pilot project, 18 months to basically get the thing dreamed up, launched, and delivered with improved outcomes. So very, very tight. Sometimes people write IRBs for, a year, right? Okay, we had to actually revamp the entire healthcare delivery in 18 months. And so for this, what you can see here is that the green with the increase in arrows are the change over baseline that were achieved. So empanelment, the clear recognition of who's taking care of this patient, where's their medical home, up 20%. Retention effectiveness, so I've identified a patient who is out of care, they haven't been getting the health care that they need, and now I'm going to put on basically like a SWAT team that's going to use the health information that's in the system to help improve that outreach. So picking up the phone, but being patient-centered. Maybe that patient has some barriers to care, and the person who's doing that outreach needs to use that information to deliver better care. So 81% improvement in that healthcare delivery, getting those patients back into care. Wraparound service, wraparound is mental health, substance abuse, dietitian. We wanted to deliver both more services effectively as well as more within 14 days. And you can see we're up on both. Sorry about that. And also, we were challenged by CMS. Okay, we don't want you to just do more and better care. We want your HAB measures, which are called the HIV/AIDS Bureau quality measures. We want them all to increase. And we don't care if you're at the national average. Can you see this bottom? National viral load. The benchmark, the top 25%, 82%. And we were targeted to hit 92%. So if you think about a randomized control trial for medication, a patient who's HIV positive is invited to take the medications, right? What is the effectiveness? We are challenged now in the clinical setting to exceed those numbers. It's really amazing. And you can see that on every measure we went up, even on the hardest, which was viral load suppression. And with that one, we just fell short of the target. Okay, so this is better care. I know it because I was part of it and I saw it in the practice. And I know it because the data showed me. So how do we do that? Well, know your cohort, get missing data, apply new knowledge, track your progress dynamically, and use the technology people, training, and leadership to change how you're doing your work. So the first lesson, of course, was about the cohort or the registry. And many times we have patients that we think are part of it could be research, but in our context, it was the clinical care delivery. We thought they were part of our registry, but they weren't. So we thought maybe they had great data in there. They really didn't. And why? Because of churn. So again, in our population, a lot of diversity, both in background and socioeconomic. About 10% of our patients were leaving and a new 10% arriving at any 6-month interval. So that's a lot of change in population. So how did we accommodate for that? Well, we had to continuously know who's part of the active cohort and who's not. And that took formalizing a retention team. Now, there was no cheating allowed. If you can't reach the patient, you cannot remove them from the cohort. That's cheating. But if you call the patient and they say, oh yeah, I'm actually living in South Carolina now. Okay. Are you transitioning to a new care provider there? Yes. Okay, well, let us help get you your records. You'll have to, make sure you go and sign a record release. But we can drop you from the cohort because you have a new care provider and you've transitioned. So we had a very formal retention process and people with very clear roles and responsibilities for this cohort. And across the country, I don't know if you know this, we were talking about disparities of care, but only 1 in 4 or 1 in 5 people across our nation who are HIV positive have met that goal of being undetectable and on therapy. So we got a lot of work to do in our field, but we know we need good data to do it. So a big part of owning a registry is maintenance. And this maintenance is really foundational. So here we continuously say, if a patient presented to the front of the clinic, did we either purposefully include them in the cohort or not include them? Maybe they came actually just for a one-time referral. So we have a way in the EHR that we continuously allocate whether they're going to be part of our cohort or not, because again, we have to put a lot of resources against these individuals to keep them engaged in care and keep everything on target. So this is a snapshot of the actual work being done. So you see a staff member here who's agreed to have a photo, and they're on the phone reaching out to our patient, right? And what we do is we create a baseline, then we have our actual, and then we start to use data in the system to predict if we're going to hit our target. So we used, for instance here, scheduled visits, added the predicted no-show rate, and then started to predict if we thought we were going to reach our target before the end of the measure period. So we were predicting ahead of time how our performance was going, and then we would sit in a meeting every week and say, okay, for this retention medical visits, what's the problem? The scheduler's on the phone. You're all booked, doc. There's nothing open. Well, we got to open more clinic sessions. How are we going to do that? Okay, well, who can work on Tuesday afternoon? We need to open 20 slots every Tuesday between now and the end of December. That gives us 50 slots. So doing math and using the math to drive how we allocate the healthcare delivery for better care. So lesson 2, can you improve your lab completion and data collection? And so missing results. I'm going to show you just a piece of the lab part that we looked at. But this is a traditional lab flow picture. So we have a patient who gives a message. They want an appointment. At the appointment, the doc is ordering, 20, 30 things. I hope I remembered the CD4, the viral load, or whatever I was supposed to remember. And then hopefully if that order's in the system, the patient can get their lab draw because they actually go, and we get a specimen, and the specimen gets resulted, right? So it's a complex system. Now, if we change the system, we can actually have more wins. So you can see win is that we actually got the result in the EHR, lose we did not. So if we use a dynamic smart set, so the patient comes into the office and the computer figures out that due to these guidelines, we highly recommend that it's time for you to get this test, and it's auto-teed up. The clinician decides do they want to sign off on it or not. and that's up to the clinician based on that conversation with the patient, then we actually can enhance and get more wins out of the lab as draw. Another strategy that we used is called bulk messaging. So in our registry, we can place mass orders. So 1,500 lab orders with one click of a button on this registry. Again, you can see why knowing who your patients are really important, because you don't want to order tests on patients that aren't coming to you for care. But if we place a bulk order, then we can have an opportunity for more orders to be placed and more patients to get to the win. So we looked at this complex adaptive system, and everywhere we could, we changed the rules. We changed how we were applying resources to get there. Risk acuity. I think all of us are wondering how these risk acuity scores against populations are going to line up for our patients. And what we've done is actually adapt in a live registry live reporting for VAX, which is a mortality risk index. So I can pull up the registry and pull up the mortality risk for that patient based on that data today. Very cool. And we've allocated the resources for the patient to get based on that score. So the next one, track your success and failure. Lesson 4, are you monitoring dynamically your progress in meeting your response? So maybe some of you have seen this. This is a model of disease management. But you can see if we have evidence-based guidelines and we have patients can do part of the activity through patient portal. Care teams can do activities outside of the face-to-face encounter. And then we can actually, through these activities, impact patient outcomes, impact patient care delivery. And like I said, you've seen this at the beginning, but I wanted to show you one more time. It's really the tracking of the reporting and how you're getting to your goal that's so important and changes how you apply that healthcare delivery. So here you could see this is what we did for all the activities that we saw green at the beginning, is because every week we were looking at how we were performing and adjusting our resources accordingly. So this part was really important, the remediation. And each component had different stakeholders, different people who might be important for that care delivery, whether it was about the lab data or retention. So this is a quick slide that I have as a proposal of how to financially help support population health delivery in this environment. And the first would be to have an innovative clinical informatics team that's supported through grant funding for a time, and then align the organization once they get the technology put in place through incentive dollars. And I think that's where you really get the hospital alignment and the leadership. So I'd like to thank everyone for having me here today, and I couldn't have done this work without our State of California CHRP grant. Thank you.
All right. Yeah, I wanted to bring this presentation because we hardly have an opportunity to hear from the people who are at the front lines and doing this important work that not only collects the data but uses it for quality improvement without the need for IRB approval. Isn't that amazing?
Although I'll say I have a couple of IRB approvals because of how I'm using the data. So, for consented patients, we're looking. But this work was really the work I wanted to share with you, was really about the quality improvement. So thank you.